tends to be carried in C fibers. Remember, A delta and C fibers are the main carriers of pain. A delta, very fast response, C fibers, non-myelinated, slow response. And in a patient with a tourniquet and having this pain, they can often have an associated increase in blood pressure. And this occurs very commonly, up to 2/3 during limb surgery under regional anesthesia, and occurring about 30 to 60 minutes after inflation. What do you do? Well, one, you can deepen the anesthesia, give supplemental intravenous agents like ketamine, dexmedetomidine, opioids. If you're using a double cuff, the more distal cuff can be deflated after the more proximal cuff is inflated, so it's like taking down one cuff and giving some relief to the tissue that's underneath it. Another thing that you can do if it's in the upper extremity, use an intercostal brachial and a musculocutaneous nerve block. The intercostal brachial nerve block is done with a ring of local anesthetic in the upper arm, and the musculocutaneous nerve can be blocked in the corporal brachialis muscle, which is below the biceps muscle. The prevention also can be to just simply deflate the tourniquet, because that's the definitive treatment for tourniquet pain. Tourniquet inflation and deflation pathophysiology. What happens when you inflate and deflate the cuff? First, inflation, as the cuff goes up, systemic vascular resistance goes up, blood pressure goes up, CVP goes up, the temperature in that non-perfused limb is going to start to go down. So you have a sink of cold blood sitting there, and anaerobic metabolism occurring with building up of lactate and potassium in that limb, such that when you deflate the cuff after 1 to 2 hours, there's a sudden decrease in volume as the extremities open back up, and a drop in systemic vascular resistance, such that your blood pressure goes down and your CVP goes down. And that cold blood that's in the extremity mixes with the blood in your core body, and there's a decrease in temperature. And the CO2 that built up in that extremity and the acid comes back into the body, and there's a transient rise in end-tidal CO2. It's not uncommon. You're barely going along at end-tidal CO2 35, it jumps up into the 50, 55 range. And if you can imagine, if someone had problems with intracranial pressure, such as let's say a traumatized person who has TBI, traumatic brain injury, with some ICP issues and fractures, and their ICP is hanging around 15 to 20, and you had a rise in end-tidal CO2, cerebral blood flow would go up with that rise in end-tidal CO2, and cerebral blood volume could go up, and ICP could go up also. Also, with deflation, potassium comes back from that limb, and you can have dysrhythmias, even cardiac arrest. So lowering of the pH, lowering of the bicarbonate level, increasing of the potassium, increasing of the lactate, decreasing body temperature, drop in blood pressure, drop in CVP, 18 keyword deflation of a tourniquet. The next is methylmethacrylate or bone cement. Picture at the top right shows a reaming of a femur. When you put bone cement and have high intramedullary pressures as it's being reamed, you can have embolization of that bone cement, or even embolization of fat, air, or bone marrow itself. So a sudden drop in end-tidal CO2 during reaming, think of some form of embolization. And methylmethacrylate, that bone cement was the key word. What does it do? Well, as it's mixed, there's an exothermic reaction that occurs, so it gets really hot. That's number one. Number two, it is associated, as it's being placed and reamed in, with hypotension and circulatory collapse in a small percentage of total hip replacements. I'm not sure of the etiology, but absorption of the volatile monomer of the methylmethacrylate has been associated with vasodilation. Embolization can be the cause. Lysis of red blood cells with the exothermic or very hot reaction that occurs. So when you're getting ready to do this reaming and bone cementing, adequate hydration is important in maximizing the inspired oxygen concentration to minimize hypotension and hypoxemia that can accompany the cementing of the prosthesis. And if you were using nitrous oxide, to shut it off before the cementing and have a higher FiO2, because there's a risk of air emboli, there's a risk of having the circulatory collapse. You would want high FiO2 and not have nitrous present that could expand an air bubble if air emboli occurred. Next group of keywords is fluids and anesthesia 2018. They're listed here in green are the ones from 2018. Serum osmolality components, crystalloid versus colloid, side effects, normal saline administration, and the laboratory findings associated with large volume normal saline administration, volume status monitoring, and burns fluid management. First of all, body water and osmolality components. Body water, the normal adult, is about 60 to 70% water. That means that if you're 60% water and you're 70 kilograms, that's about 42 liters of water. Our percent body water decreases the more fat we have, and we have more fat as we age, and females also have more fat. Body water in general is distributed mostly intracellular, 2/3, 1/3 extracellular, and the osmolality of our body is mainly determined by how much sodium we have. And we can estimate our normal osmolality, which is about 285 to 295 milliosmoles per kilogram, by 2 times the sodium plus glucose over 18 plus BUN over 2.8. So you can see that if your sodium is about 140, that is by far the major component of our normal body osmolality. Even if the glucose was 1,000, so you have to have really big elevations in glucose and BUN for them to affect osmolality. If we look at our IV fluids, D5 is hypoosmolar, 0.9 is hyperosmolar, LR is isoosmolar, and hypertonic with 3% saline is very hyperosmolar. The picture at the bottom right shows percent body water at birth, about 80%, normal adult 70%, and an elderly person 50 to 60% body water. Again, the key word was osmolality components, and the main take-home message is that sodium is the major component. Crystalloids versus colloids and the side effects. If we have a healthy glycocalyx, that little lining of our vascular endothelium, the colloids stay intravascularly, while crystalloids go through and into the interstitial space. Intravascular expansion or hemodilution occurs as we give a bunch of fluids. If we pour in a bunch of crystalloid, we have hemodilution that occurs. We pour in colloids, it stays intravascularly, draws fluids in, and hemodilution occurs. Colloids, such as 5% albumin, approximately for every cc that we give, 1 cc stays intravascularly, so 100 mils of 5% albumin would give you approximately 100 mils of intravascular volume expansion, as opposed to crystalloids like lactated ringers and saline. Although there's controversy about this, approximately 3 to 1, or we have to give 3 times as much crystalloid as we want to stay intravascular. So 100 mils of lactated ringers, about a third of that would stay intravascular, or about 30 mils. So if you gave 100 cc's of albumin and 100 cc's of saline, the albumin would more hemodilute the hematocrit than would 100 cc's of crystalloid, more bang for the buck intravascular volume expansion. Albumin is important for oncotic pressure. Sodium is important for osmotic pressure. Both crystalloids and colloids, when given in large amounts, can dilute the platelets and dilute the coagulation factors like factor VIII, and you can get into problems with dilutional coagulopathy, which is large volume resuscitation of both crystalloids and colloids. There's little difference in the efficacy of crystalloids or colloids at your choice, volume expander, but you can imagine if you resuscitate to equal intravascular volume with crystalloids or colloids, you're going to have to give a lot more crystalloid, and you end up with the Michelin Man with large volume peripheral edema, more peripheral edema with crystalloids than colloids. Head-starch can cause problems with coagulation, and the kidneys, although there's some debate about this, dilutional coagulopathy with head-starch reducing factor VIII when it's given in large volumes. It's recommended if you use it not to exceed 20 mils per kilogram, or approximately 3 bags of it for a 70 kilogram person in a 24-hour period. And there's question about it being associated with renal injury in critically ill patients who have renal insufficiency. Let's look at fluid types and components before we talk about saline and the laboratory findings, which was the key word. Normal saline is under 50 so this is a lot of fluids, hyperchloremic, and the osmolarity is slightly hyperchloremic. Has a lactate in it, has an anion. Lactate is metabolized by carbonate as a citrate and acetate if you have a normally functioning liver. And the osmolarity of Ringer's lactate is 274. Then we'll skip over to D5W, which the osmolarity is hypoosmolar, low osmolarity. And when dextrose is metabolized, it leaves water behind and it goes to all the water spaces of the body. Albumin is mixed in with some sodium and chloride, and it's usually supplied as a 5% solution, and it is hyperosmolar. Now let's go to our key word, which is saline laboratory findings. If you give 0.9 normal saline, large volume, 5-10 liters of normal saline, there's a lot of chloride being given because normal saline has chloride 154 milliequivalents per liter. Our body doesn't have 154 milliequivalents of liter per liter in our plasma. So hyperchloremia ensues. Lots of anions around, chloride. The strong ion difference, which is a difference between the positive charged cations and the negatively charged anions. If you have more anions now, it reduces the strong ion difference. And you have to keep electrical neutrality in the body. So if you gained a bunch of negative charged anions, water has to dissociate to hydrogen ion to keep electrical neutrality. So acidosis ensues. So large volume normal saline results in a hyperchloremic metabolic acidosis. Large volume lactated Ringer's. If lactate is metabolized by carbonate, you get a metabolic alkalosis. And lactated Ringer's also has calcium in it, which can precipitate citrated blood if it happened to be infused at the same line. D5W we said was hypoosmolar. It can actually increase brain water in a traumatic brain injury patient. That would be one reason for not giving D5W. But another reason is increased glucose in the presence of an ischemic brain worsens ischemic brain injury, and we tend to avoid sugar-containing IV solutions in patients with brain injury. And lastly, a rare disease, periodic paralysis, the hypokalemic form. If you give glucose to a person with hypokalemic periodic paralysis, as their glucose goes up in their blood, their insulin kicks in and to drive the glucose into the cell. Well, insulin also drives potassium into the cell, and if you drive potassium into the cell, you can get hypokalemia, and hypokalemia is the stimulus for the periodic paralysis or loss of skeletal muscle strength. And so giving sugar to someone with hypokalemic periodic paralysis can induce that paralysis. Our last couple slides here, or keywords. The first here is assessing volume status, and we can do that with urine output, blood pressure, cardiac output, the size of the left ventricle with echo, wedge pressure, CVP, and heart rate. But one of the things we use now is fluid responsiveness, which is a dynamic rather than a static parameter, trying to predict what's going to happen if we give fluid to a patient. One thing that you can do is simply lift the legs of a patient, which is like giving them some volume, and look what happens to their stroke volume if you're measuring it, or look what happens to their blood pressure. And if it goes up, you can say, aha, if I give fluids, their blood pressure is going to go up. Probably can give fluids. If it went down, you'd say, ooh, I might be at the end of my Frank Starling curve. I better not do that. Let the legs back down. No harm, no foul. Now, we use heart-lung interactions during mechanical ventilations to measure things like pulse pressure variation and stroke volume variation to try to predict what's going to happen if we give fluids to a patient. So if you have someone being mechanically ventilated at least 8 mils per kilogram type volume, and neuromuscular blockade is present, so they can't be breathing spontaneously, then we can measure stroke volume variation and look at pulse pressure variation, like in the graphic at the top right. And you can see initially, as inspiration kicks in, the lungs squeeze the blood vessels in the chest, and more blood actually goes to the left side of the heart, and stroke volume initially goes up, as does the pressure. So stroke volume and pressure go up, but you all know that if you hold an inspiration and raise intrathoracic pressure, eventually the blood pressure and stroke volume goes down. And if you hold really high peak airway pressures, intrathoracic pressures, keep the bag full and squeezing and giving large high pressure breath to a patient, and watch your A line, the blood pressure goes down, you can actually cause cardiac arrest if you hold high pressure ventilation for a long period of time. So the initial effect, increases the stroke volume, increasing the pressure, but then look at what happens to the pressure. It goes down at the end of inspiration. And if there's big differences between inspiration and expiration of the stroke volume or the pulse pressure, we say, aha, that's stroke volume variation or pulse pressure variation, they need fluids. Another important point is the Bainbridge reflex, which is an atrial reflex. If the atria is stretched, it's overfilled, the heart says, I need to make the left atrium and the right atrium smaller, so the heart rate picks up, and in an attempt to reduce the size of that atrium. And conversely, if the atrium happened to be underfilled and small, the heart rate goes down very hard in an attempt to give more time for the atria to fill adequately. The last slide, keyword, is burns and fluid management. And the Parkland formula should come to mind when you think about fluid management for a burn patient. With second and third degree burns, we use lactated Ringer's, crystalloid rather than colloids. Colloids can leak out and increase edema. And the magic formula is 4 mils of crystalloid per kilo per percent burn during the first 24 hours. And you give half of that calculated volume in the first 8 hours, and the second half of that during the next 16 hours. The rule of nines can be used to estimate how much surface area of the body is burned. A patient's hand can be used to approximate 1% of the body surface area. In extremity upper is 9%, extremity lower is 18%. So this rule of nines can be used to estimate the percent burned. The modified Brooke formula is another formula to estimate how much crystalloids to give give. However, the Parkland formula is the most commonly used. And this ends our 2018 multi-topic keyword review. I hope you have a great day. These are pictures from Kentucky and a winter ride I recently took on my bike in Kentucky. I hope you have a great day.
This is part one, selected respiratory keywords for 2019. Dr. Shell has two other presentations on the same subject, but he divided the keywords between the solution meeting. These are keywords I was assigned. The keywords covered in this presentation appear in red. The first subject to be discussed is problems related to pulse oximetry. If I were writing questions on this subject, I would focus on factors associated with pulse signal quality, or factors that produce inaccurate results. This slide shows a normal pulse oximetry waveform and examples of waveforms with poor signal quality. It would to be reasonable to present a waveform with poor signal quality and ask the most likely etiology of that waveform. These are the results of a meta-analysis that evaluated 169 studies. Dyes that have a blue coloration have an impact. That includes methylene blue, isosulfame blue, and indigo purple. The role of white light has been argued, but clinical experience indicates there are times in the operating room when covering a probe with a blue towel or the foil package from an alcohol swab will result in reading or not being obtained before. As expected, factors causing probe confusion are associated with poor signal quality. Note that there is some disagreement about whether or not the use of vasopressors results in poor signal quality. I suspect the truth is that it's dose related. In any event, the lack of concurrence on the subject makes it difficult to use as the basis of the question. The impact of nail polish on pulse oximetry is also related to some debate. The original work done in 2002 showed that black, green, or blue nail polish resulted in a reduction in the number displayed by the pulse oximeter. More recent work, done in 2005 and 2006, disputes that claim. The impact has been attributed to nails and pulse oximeters. The role of bullet nails is also questionable. The original work done with clear bullet nails has questionable applicability to today's environment. Nonetheless, a report from the European Society of Anesthesiologists in 2018 suggests that neither nail polish nor acrylic nails have a significant impact on pulse oximetry, as evidenced by the fact that no readings vary by more than 2% from the actual value. Motion artifact is an obvious problem, not so much in the operating room as in the post-anesthesia care unit or the ICU. Recognize that electrical interference may compromise signal quality. The issue of a dirty sensor has probably been all but eliminated with the use of disposable probes. Nonetheless, be aware of the fact that blood covering the LEDs in the probe may result in compromised signal quality. Now it's time to consider the accuracy of the readings. These are the results of a meta-analysis that evaluated 169 studies. Note that not all factors reported to influence the accuracy of pulse oximetry are universally accepted. For example, one study evaluating the impact of anemia on the accuracy of pulse oximetry reported it had no impact even as low as a hemoglobin of 2.5. The issues of motion artifact, decreased perfusion, dyes, and red light have already been discussed. It is worth noting, however, that a prior mark in terms of dyes is a classic